Alright, so this is my video for the Gamma 3 back table layout. I do not have access to instruments, so I thought it would be sufficient for me to just walk you through the surgery and explain step by step how we do it, at least here in Kansas City. So first things first, I'll go over the disposables we open up. We open up 6 disposables for a Gamma nail. We open up 2 3.2 by 450K wires. We open up 1 3 by 1000 long ball tip guide wire. We open up 8 by 510 reamer shaft, closed tube clip, and a 4.2 by 180 drill bit for a long nail, 4.2 by 300 drill bit for a short nail. So first things first, the starting point for a Gamma nail is the tip of the grater troke on the AP and 1/3 anterior, 2/3 posterior on the lateral view. So you take your 3.2 by 450 wire and you make sure that you get the tip of the grater troke. At that point, they're going to take a lateral and ensure that they're where they want to be on that view as well. And it's important with any nail that you have a good starting point, because that is the most important thing, and that will make or break your procedure. So you drive the starting wire down to the lesser trochanter, and at that point you can now ream proximally. So you have a couple different options for reaming proximally. You have our intra-reamer, which is 15.5 millimeters in diameter, which corresponds to the proximal diameter of our long nail, or sorry, of our nails, long or short. And so if they do not want to do that, alternatively they can use the awl. But one thing about that, and a lot of times surgeons forget, is that if you use the awl, you still need to go back proximally with the 15.5, either Bix cut reamer head, or just make sure to go back and use the entry reamer after they've used the awl if they wanted to take a less aggressive approach initially. So you have your starting wire, your 3.2 by 450, tip of the grater troke, 1/3 anterior, 2/3 posterior. They like their starting point. They take their starting reamer loaded up onto a Jacobs chuck with your tissue protection sleeve. They ream proximally. Now at this point you can use the long 3 by 1000 ball tip guide wire. You drive that long ball tip guide wire down, and then now at this point you can then measure. So you have a long ruler. A lot of times it's 2 pieces. You might have the scrub tech assemble it. Sometimes it's already assembled. I always tell the surgeon that we're using an 1000 wire because it has the option of an 800 wire as well. And at that same time, I let them know that our nail comes in 20 millimeter increments. Excuse me. So let's say we measured a 360. We now know the length of the nail. We need to figure out 2 more things. We need to figure out the neck angle, which is for a long nail, 125, 130, 120 would be special ordered, or if we're doing a short nail, it's going to be 120, 125, 130. And just a side note, those short nails come in 10 and 11, which is 170 and 180 millimeter lengths respectively. And those long nails, as I stated, only come in with the 125 and 130, unless you want 120, it's special ordered. And the diameters of options of that are 10, 11, and 13. So we measured a 360, and doctor thinks it's pretty standard neck angle, so we go with a 125 degree neck angle. At this point, we need to figure out the diameter of the nail. So we already have our long ball tip guide wire down there. Now we load up our 8 by 510 reamer shaft onto a Hudson, and we load up a Bix cut reamer onto there. We start with the 9, and we work our way up in 0.5 millimeter increments. An important thing with Gamma nails is that you over ream by 2, and so our smallest nail is a 10 millimeter nail, so you at least need to get to 12 millimeters distally. So say the doctor starts to feel pretty significant chatter around 13 millimeters. He likes an 11 nail, so he likes an 11 by 360 by 125. At that point, you can then have your circulator open up the nail. So prior to all this going on, before the surgery had started, I had been working with the Scrub Tech, and I had the Scrub Tech assemble the target sleeve to the target arm, and you align the arrow to the arrow, and then once you put the arrow to the arrow, you adjust it over to the degrees that you want, so 125 degrees in this instance, and then the little swivel lock on the bottom will lock it into place. And when you do line the arrow and arrow, you need to push up so it like kind of form fits or snap fits, whatever the term is for that. So now at this point you have your nail holding bolt. I usually leave that, I don't put it in there just because I've seen it fall, so I leave that just sitting out by the targeter, and I've opened up the nail, which has the set screw in it. I make them put that set screw in like a little medicine cup or just somewhere safe, obviously. So they get the nail on. It only fits one way onto there. They take the pumpkin head screwdriver, the pumpkin head, acorn, whatever you want to call it. They tighten the nail on there, and as I said, it only fits on one way. And at this point, I usually have the Scrub Tech, or I always have the Scrub Tech, target the nail with the double sleeve just to ensure everything's lined up, and I make them show it to the surgeon, so they're pleased and they know everything's lined up. Typically, it's pretty sufficient for the surgeon to just target the double sleeve, make sure it's hitting that lag screw hole. We don't really take that triple sleeve if you're doing a short nail, and a long nail obviously you would have to do perfect circles anyway. So once you've targeted that, you have the impactor already screwed onto the target arm, and you start driving the nail down over the long ball tip guide wire into the canal of the femur. Use your slotted mallet to get to position it to where you want it to be. The important thing with Gamma Nail is that where the nail is placed is based on the trajectory of the lag screw. So at this point, I'm usually standing by the monitor, and I'm showing them where the end of the nail is, as well as holding my pin up to the trajectory of the lag screw, and to where that wire is going to be. And so a lot of my surgeons like posterior and inferior. Some surgeons like center. I'd say the new craze is probably more posterior inferior. But so at this point, you can then take your other 3.2 by 450 wire and send it through the double sleeve with the K-wire sleeve in it, and so you put that, you drill the wire into the femoral head, and you need to make sure you're taking both lateral and AP views at this time to position it where you want to. The threads are 10 millimeters, and when we go to measure it with our white ruler, it measures to the base of the threads, and that's important because that also is a good tool for surgeons to use to realize their apex distance. So you have 10 millimeters on the AP view and 10 millimeters on the lateral view. Sorry. And so they can use that as a tool to help get good tipped apex distance. So they measure their wire, say they measure a 95. At that point, I ask them, I generally say, are you going to do any compression? Are you, where do you want to put the screw? Do you want to put it to the end of the wire? Do you want to put it about halfway? And they usually give me some sort of answer. And I also make sure that the sleeve is down on bone, because if it's not, then you're going to measure a little bit long and you need to take some off from there. So say they decide to go with a 95 millimeter lag screw. You then have your lag screw reamer, which you can set the dial to 95. And so the way you do is you pinch the two dials together, you slide it so it says 95 in the window, and you pull it apart for a positive stop or a positive lock. And we usually use that lag screw reamer on the Jacobs chuck just because we found that little adapter piece kind of makes it wobble a little bit. So we, in between all this step, I have the Scrub Tech take the Jacobs chuck from our entry reamer and put it onto this lag screw reamer. So at this point, you take out the K-wire sleeve, you have it set to 95, you drill or you ream to 95, I go get the 95 millimeter lag screw, and the circulator opens it up, and now we get it assembled to the lag screwdriver T-handle, and so the scrub tech grabs the pumpkin head. We have that ready. I usually have the scrub tech put the the screw so where it's down onto the table. The T-handle's up here. They tighten them up on the little thingy-majig. I know that's not the correct terminology. I'm blanking on the word. They tighten it with their hand first. I usually tell them it doesn't need to be crazy tight, just nice and snug, and then just take the pumpkin head screwdriver to just make it a little bit more tight. At this point, they're then ready to hand that to the surgeon. The surgeon inserts it over the wire, and they're, again, once it's inserted, they're making sure they're taking both AP and lateral views to make sure that the screw is where they want it to be. And I'm standing next to the X-ray, pointing out the end of the lag screw and helping them out any way I can. Now it's time. At this point, probably the scrub tech has already put the closed tube clip onto the targeting arm to help with the set screw. So I remind them to use the flexible screwdriver, get the that ready with the set screw on it. And so they take the set screw with the aid of the closed tube clip. They can get that set screw to lock that lag screw into place. And so it's important also with the lag screw, I didn't mention this, is that it's either parallel or perpendicular to the targeter, and or else the set screw won't catch into those little grooves. And you can either back the set screw off a quarter turn depending on the fracture type and surgeon preference as well. So once they have that set screw down, one way to check to make sure that it's locked into place is to kind of give that lag screw T-handle a little jingle to make sure it's not loosey-goosey. If it is, then you know that you're not locked into place. So your set screw's got your lag screw locked into place. At this point, you can then now hand the surgeon the pumpkin head screwdriver. They'll use that on the lag screwdriver, and then from there they'll take the lag screwdriver off, and then I have the scrub tech have a naked or an empty wire driver so that they can take that wire out of the double sleeve, and from that point you've got your lag screw in, and now we move down to perfect circles for a long nail, or we put the targeter onto static mode for most likely static mode for a short nail. For this video we'll talk about the perfect circles. So we use our 4.2 by 180 drill bit. Usually surgeons have their techniques and what they're comfortable with on how to get their perfect circles. So they use their 4.2 by 180 drill bit. They drill that to the far cortice, and then at that point they can either take the drill bit out and measure with the standard smaller depth gauge, or they can keep the drill bit in and measure off of the sled, or they can use the calibrated drill bit. You know, I'm not sure off the top of my head now that I said that the 181 is calibrated. I think that one used the sled. The 300, 4.2 by 300 is calibrated if you're doing a short nail. So would use the sled if you keep the drill bit in, and at that point you use your short self-retaining screwdriver to insert the distal locking, the 5mm distal locking screw in, and then if they haven't already, give them the pumpkin head so that they can take off the targeter, and then you take your final x-rays, make sure everything's okay. You have the option for an end cap, yeah, that's my Gamma 3 back table layout. That was probably a little bit long. I'll work on consolidating it for the next one. Thanks.